Okay, we're going to go ahead and get started. Good morning, everyone. Welcome to our fourth webinar. This is a series, the fourth in a series of 4 webinars that we have been hosting throughout June to coincide with Men's Health Month. Today, our topic is COVID-19 and men's health, and we're very pleased to welcome you to our fourth and final webinar for this series. Just a few things. This webinar is sponsored by the Making Connections for Mental Health and Wellbeing Among Men and Boys in the U.S. grant, which is funded by the Movember Foundation and coordinated by the Prevention Institute. And our site here in Oklahoma is with the Southern Plains Tribal Health Board and the Oklahoma Tribal Epidemiology Center. My name is Susan Gay, and I am the program coordinator for the Making Connections grant. And with me, I have my teammate Idalmi, who is the program assistant, and we have worked together to coordinate this series of webinars. Today, we have 2 presenters, one from our funding organization, the Movember Foundation, Mark Hedstrom, and we have Dr. Sal Giorgianni from the Men's Health Network, one of our partners in this initiative. I will go ahead and introduce them shortly, but just a few housekeeping things. We will have a segment for questions and answers at the end, where you, our participants, will have an opportunity to ask questions of our panelists. You can either type your questions in or raise your hand, and I will unmute you and allow you to ask those questions yourself. We will have 30 minutes for each presenter. So let me go ahead and introduce our speakers. Dr. Sal Giorgianni Jr. is the principal founding partner of Griffon Consulting Group, Inc. GCGI provides services in health and regulatory policy, medication therapy management, clinical pharmacist practice, as well as voluntary health and pharmaceutical industry consulting. He is the author of over 70 peer-reviewed and general public publications in men's health, health policy, and pharmacotherapy. He is an advocate for men's health and a recognized expert in men's health. He is one of the founders and chair-emeritus of the American Public Health Association's Men's Health Caucus and is currently senior science advisor and spokesperson for the Men's Health Network in Washington, D.C. He holds a Doctor of Pharmacy and a Bachelor of Pharmacy degrees from Columbia University in the city of New York. He has held faculty appointments at Columbia University and as founding faculty and executive administrative faculty at Belmont University Colleges of Pharmacy. So welcome, Dr. Sal.
Thank you so much for having me.
You're welcome. Mark Hedstrom is the executive director in the US for the Movember Foundation, the global charity focused on men's health, which funds over 1,250 innovative projects across 21 countries. To date, the charity has raised hundreds of millions of dollars from men's health programs supporting 3 critical areas: prostate cancer, testicular cancer, and mental health and suicide prevention, and suicide prevention. Mark is responsible for the U.S. strategy, management, and operations of the Global Men's Health Foundation. In this role, he oversees community and corporate engagement, partnerships, marketing, public and government relations, finance, operations, and human resources. He was previously the Global Director, Programs Commercialization for Movember from 2017 through 2018. Before joining Movember, Mark held various positions, serving as the manager of global strategy and planning at Oakley, a global consumer packaged goods company, as the chief financial officer at the Arbor Collective, a board sports and apparel company, and as a director of operations and finance at the Advisory Board Company, a global technology and consulting company. Mark holds a BA in anthropology from the University of Chicago. He grew up outside of Boston, but now lives in LA. He is the third out of three most important humans in his family, and just ahead of the two dogs, David Ortiz and LeBron James. Welcome, Mark Hedstrom. So at this time, we're going to go ahead and get started with Dr. Sal.
All right, let's thank you very much. Let me see if I can bring up my screen here. All right, I think, well, actually that works. I'm impressed. This technology kind of befuddles me. I'm pushing 70 and I'm always amazed at this technology. Well, thanks very much for having me on the program. I did want to set the stage a little bit for some of the very important background information that I think is very relevant to understand about the overall status of the health of men in America, as well as how it applies to the pandemic that we're experiencing now, which many of us believe may not be the first or the last thing that we see. Just for my reference, because my screens are maybe out of sync, are folks seeing my title slide, or they're seeing the slide that says Reach Men and Their Families?
We're seeing the slide that says our mission, Reach Men and Their Families.
Oh, all right. Well, okay. Well, let me back up for a second.
Okay.
Thank you. I do apologize to the audience because I'm seeing two different kinds of slides here. Well, there we go. Okay. That's what I wanted to start. Okay.
Okay.
All right. The mission of Men's Health Network, it was founded in, about 25 years ago, and our mission is to reach.
You hear me? Just a minute.
Yes.
You hit on slideshow. That way your slides will. There we go. Okay.
That's perfect. Better?
Yes.
Okay. All right. So I'll start again. I apologize to the audience. Men's Health Network has been around for about 25 years, and we were one of the first organizations that looked at the overall comprehensive health of boys and men. Our mission is to help men achieve better health and wellness where they live, work, play, and pray. Our focus is not just on the men, but it's also focused on the families that they support. We do a lot of health prevention screening programs. We develop a lot of educational materials. We're in the process of developing some for COVID-19 now, and we have several items already in overall health. They're available, a lot of them free on our website. We also engage in legislative activity and public advocacy. It was not easy in the beginning to develop a dialogue on Capitol Hill and in state government houses on the health of men overall. And Men's Health Network worked a long time to get it to be a point of priority for legislators and public health officials to think about men as a category. In fact, one anecdote I think helps understand the fundamental problems that people have had in understanding the health of boys and men is that the American Public Health Association, which has been around for about 120, 130 years, and is a premier public health association in the world, only recognized men as a demographic circa 1998, 99, when Men's Health Network and others approached Public Health Association to create a section on men's health. And then that section was formed in the early 2000s and became a formalized caucus section of APHA. And what that speaks to is the fact that men were not recognized as a specific demographic that needed some particular focus and coordination of activities. And that is one of the major things that we've been able to accomplish. We also provide patient navigation activity programs and such to help men get to health. Here are some of the awareness periods, as we call them, that focus on particular disease conditions. June is Men's Health Month, and Testicular Cancer Awareness Month is celebrated in April. Prostate Cancer Awareness Month in September. Mental Health Month in May, and then Mental Health Awareness Week in October. And we've been very gratified at MHN to see how the programs that we've established have been growing. So now we have a great program in the springtime for Men's Health Month, and another fantastic, wonderful, powerful program, which my colleague speaker will talk about, Movember in the fall. So that we're actually focusing on guys twice a year now, when almost 20 some years ago there was no focus on guys. Men's Health Month was established in 1994. This is a little bit of an informational piece on what we do during Men's Health Month. I think you can read them yourselves, but it is awareness, prevention, and education, and a focus on families. That's our 4 pillars for how we position Men's Health Month, and Men's Health Week follows soon thereafter. So to help understand why COVID is a particular problem in men, and I'll show you some staggering strategic statistics a little bit later on. Let me just lay the groundwork here, because a viral infection, an infectious disease, does not come about in one way. It affects everything that is underlying in the basic health of men and boys. So when a virus infects, or any infectious disease take hold, it's layered on top of all of the other health problems and all of the other biologic and genetic factors associated with that now host organism. So to understand why COVID has become a particular problem in boys and men, when men are disproportionately affected by COVID, both in terms of being infected and also the death rate, mortality rate from COVID, let's take a look at some of the statistics here. Men generally live sicker and die younger than do women. That has been the case, unfortunately, since the 1950s, when the lifespan for men has fluctuated between 5 and 6 years less for women. And most of that, and I'll show you a slide later, is for, by and large, preventable, or at least very manageable diseases. And that's a shame. There should be no reason why men die much earlier than women, if all things were equal, which they never are. Men are dying at a higher rate. Out of the 10 top leading causes of death in the United States, and it parallels throughout the world, men lead in those deaths in 9 out of the 10. That's a very important statistic to keep in mind, and I'll show you some slides there when we talk about COVID. Part of the problem is the way men participate in healthcare. They have fewer visits to physicians, and they wait a lot longer in the disease process to go get help. Guys, even when in pain, studies have shown they wait far longer than women do to get help, and that just does not help address the fundamental problems. Also, men perceive being unhealthy as unmanly and vulnerable, and that too is a sociologic detriment. Here's a little bit more data about the life expectancy, and you see it's been broken down a little bit. I do have some information on Native American, Alaskan Native individuals later on. This was pulled from some data from the CDC, and you can see that when you look at the mortality rates across several different demographic categories, men just don't fare well. And that is something that we're trying hard to address. Well, I was able to pull a little bit of information out from the U.S. Indian Health Service about the mortality rate for American Indian and Alaskan Native individuals. And here you also can see that American Indians and Alaskan Natives born today have a life expectancy that's 5.5 years less than U.S. population in general. So it actually is a little bit shorter than the male population in general. And then the causes of death, are hard for the U.S. to track for some reason at CDC, because I did find a very interesting statement that the causes of death on many statistical records for Native American and Native Alaskans is not easy to find, which I find stunning in the 21st century. Well, maybe it's getting better with the young folks out there, that they are much more aware of health and wellness, and they understand these numbers, and they're taking better care of themselves. Unfortunately, that's not what we see. This was an interesting study that we picked up from Blue Cross Blue Shield done in 2017, and I'm going to guess that the data looks even more surprisingly bad now, 3 years later. And you can see that about age 27, the health status of all millennials begins to decline at age 27. So when you're thinking of strategies to approach the health of anyone, but let's focus on the guys today, you really need to inculcate those strategies early on, because now the health status is starting to decline much earlier than it had before. And keep that in mind when we talk about the impact of COVID infections in the guys. Here's a very, 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 very sad and very, very difficult statistic to digest. And this has been the case for a long time. In 2018, the CDC issued some statistics which really rocked the public health world, and I'm sure Mark will address this as well. It's part of the core mission for his foundation, is a suicidality in boys and men. And what happened in 2018 is that there was the rate of increase in suicides dramatically increased in men. And the other thing that well, in general, it's always been very high, about 3.5 to 4 times higher in men than in women across any age category. And if you look at the age category, I don't know if you can see the pointer, somewhere around 75, it goes dramatically up. Historically, it goes up. Unfortunately, what we noticed in 2018, and this is across all of this is data on Native American and Alaskan Native individuals, it's 3.4 times higher per population, is an increased 77%. So despite access to healthcare and other things, the rate of suicidality is increasing dramatically. And what we see in this population, as we now beginning to see in the general population, it's hitting earlier in the age 10 to 24, with a stunning 37% of suicides in this population occurring in the age group of 10 to 24. I'm going to guess it's skewed higher in the age, but not. So you would think that people, when they're depressed or when they're anxious or when they're having behavioral health issues, they bring it to the forefront. Women do, men don't, for a lot of sociocultural reasons. And what we also found very, very disturbing is that most of the men who committed suicide had no diagnostic history of any depression or depressive condition or mental health issues. So that really speaks volumes about where some of the problem is. We also see the vector of the statistics changing, where it had been very, very high in the latter years when men lose identity and focus, and their careers are changing. But now, unfortunately, because of what most feel is substance abuse, we're seeing it rise in the middle ages of men when they should be the most productive, and very, very tied into issues of substance abuse. And that, I think, talks a lot about where we need to go. I have some statistics here. You can read them. What I would like to focus on a little bit is this very important quote from Surgeon General David Satcher about the issues of people of color. People of color, both adults and children, are less likely than their white counterparts to receive needed mental health care. People of color also face additional barriers such as poverty, lack of services and supports, pervasive stigma and prejudice, language barriers, cultural competencies, and service delivery. So there's an awful lot of work to go, and we just recently had a very large conference on this issue of mental health, and these barriers, unfortunately, still exists. Fundamental problems I alluded to before is that men just do not go to the doctor as frequently or as often as women do. You can see some statistics from 2012, and the summary of this rather busy slide, but very important slide, is that guys really go to the doctors at least half as often as women do for care and diagnosis. Subtext to this data is that they go later on in the disease process, as I mentioned earlier, and that just does not help their health status. Why men don't go? It's very socioculturally steeped, as well as steeped in the issues of access and payment. But these are excuses. I'm sure any of you tried to get a guy to go to the doctor, whether it's a brother or a husband or a loved one in your family, recognize some of these excuses, but the point is they are there. These are barriers to why guys do not seek their health care. The most important, I believe, is that men do not make health a top priority. I always talk about how men need to take a page out of the women's health playbook and then really make personal health their personal responsibility. Whereas now men usually sort of defer and they get goaded to going to the doctor. Men have to do it on their own because it's important to them and their children. Some other points here: make prevention a priority, know your numbers, ask questions, it's your body, start early, take advantage of all of the free community health care services that are available to you, and then involve your family in your health. These are things women and girls do intuitively early on, but guys somehow do not. Okay, so here's another slide. I'm not going to read all of this in the sake of time, but the point here is that men are disproportionately affected by COVID, not only in their ability to contract the disease, but also in a decreased ability to fight the infection. There are lots of theories as to why this happens, but they're complex and we really don't understand it. But the fact of the matter is men have to be particularly vigilant as we're moving into the fall season for infections, pulmonary infections, regular flu and COVID, we believe. And watch, men get tested less frequently than women. Men are majority of the overall mortality, the death rate. 59% of all COVID cases are found in men, and the mortality is higher in men as well. This isn't just a U.S. phenomenon, by the way. So one can argue it's lifestyles of the crazy guys in America, but it's not. We see this worldwide, and that is very epidemiologic work, which is now continuing. But the fact of the matter is, guys, be very careful, be very engaged. We believe that education is extremely important, and Men's Health Network is looking to get funding to do education in the area of COVID. One of the things Men's Health Network does very, very well, which we don't see in too many sectors, is we create materials that resonate with boys and men in different demographics. Men's Health has a 25-year range of experience doing that. Mitigation, mental health, and exercise are extremely important. Lifestyle management is also very important.
You have 10 minutes.
Oh, I'll be done less than that. Okay, thank you. Men have historically lower rate of immunizations than do women. And as we move into a period now where mitigation continues to be important, social distancing, wearing masks, being careful with hand washing, watching how you interact with your environment, as that continues to be very important, and we're all tired of it, me included, we still have to be vigilant, and men can be, when they're motivated, be very vigilant to these things. But as we move into a phase where we most likely will have more than one effective vaccines, men have to understand the importance of vaccination in general and buy into vaccination. And I believe that that'll be a challenge for public health officials throughout. Historically, men get vaccinated less frequently than do women. And that is a very, very important thing to keep in mind. When you think of how we as a society are able to withstand and then become immune, is this herd immunity where you have to get 40 to 60% of the the population base core immune to a viral infection, to curtail or to prevent its widespread dissemination throughout a population. If we don't have vaccinations in men to the same rate as we do in women, and in younger men as well, it's not going to work. You really can't weed half a garden. Vaccination is extremely important, and that is a big challenge Men's Health Network sees coming down the pike. This is sort of a summary. Men's Health Network has a 25-year history of reaching men through directly or through their families, those who care for them. We have a network of over 900 advisors throughout the United States and several outside of the United States that we tap into to bring messages, to help us develop material, educational, and advocacy positions. We are signatories to many, many position papers across the continuity of health issues for boys and men, everything from hypertension and prostate cancer to now this infection, COVID. We also are looking very carefully at how to make telehealth more welcoming to men and boys, which we believe is going to be very important. And we have a whole array of materials, which at the website, menshealthnetwork.org, you can find and bring into health programs that you may be doing. So as promised, I'll get a summary slide up there. Here's our website. We're also, of course, like everybody else, on Facebook and Twitter, and we do constant blogs, and there's a lot of great information in there. So thanks very much for the time. I'm done.
Thank you, Dr. Sal. Thank you. You still have like 6 minutes left. So, but someone wanted to know if the slides will be available. You can speak to that now, or you can speak to that at the end.
It's fine with me as long as it's good for you. You can send them over to you, and you can post them and make them available to all the folks who want to look at them. Okay. There's a lot of data in them. I'm kind of a reforming academic, so I love the data.
Thank you so much. And again, the recording will be posted eventually on our website as well. Mark, we will turn it over to you, and that way, you know, you can have time, and we can have more time for question and answers. So over to you, Mark. We can't hear you. Unmute.
Yes, coming off mute right now. Okay. So everyone can see the presentation here. So thank you all for taking the time today and this morning. And Sal, that was really great to see that there's a lot of overlap with what Sal was talking to and what the Men's Health Network focuses on, and what Movember does as well. So good to see that synergy there. I think it's going to take a village and a community and a society to fix some of the challenges that Sal laid out, and also what Movember sees. So a little bit about Movember and where we started. You know, we're known as the organization that sits behind the mustache that gets grown every November. And so as an organization, we've been focusing on men's health since about 2003. So we're founded in Melbourne, Australia back in 2003, and actually grew up in the world of prostate cancer. So we are a heavy funder of biomedical research, looking for both therapeutics and diagnostic improvements for prostate cancer in men that live with that disease, as well as survivorship in that space. But as we look back and talk about the specific men's health issues we focus on, it's the same set of statistics that we see and that are troubling to us. So to what Sal was saying, and what we see is obviously men die 5 years earlier than women. I think to acknowledge here, if you look at Black men in America, if you look at Native American men in America, those statistics are even worse. It's closer to 5 plus 3 or 4 years in addition to that. So men in disadvantaged or marginalized communities are dying even at a younger age. So there's a real challenge with that. And we'll talk a little bit about some of the work that we're doing in ANADARKO, Oklahoma, with young men and helping them navigate through some challenging times earlier in their lives. As we look at the cause areas that we focus on, which are mental health and suicide prevention, prostate cancer, and testicular cancer, some of what Sal was talking about and some of the challenges that we see is, in mental health and suicide prevention, 3 out of 4 suicides in the US today are men. So if you look at the statistics, it's just over about 47,000 Americans decide to take their own lives each year. Of that, about 34,000 are men. And to what Sal was saying is that there are some biological underpinnings to the challenge, but a lot of these are preventable issues. So how do we engage in that suicide prevention space to really understand how we can help and prevent suicide from occurring? As you look at prostate cancer, 1 in 9 men will be diagnosed in their lifetime with prostate cancer. Just to acknowledge, in African-American men, that actually is a 2.5 times incident rates against Caucasian men. So those men have a higher risk for the disease, and they also tend to present later because of health inequity or access to care. So one of our challenges in that space is how do we engage populations of men that are more at risk for prostate cancer amongst the general population, to understand how do we help support them, how do we educate them, how do we raise the awareness, and then ultimately how do we work on the equity and access to care for those populations of men. And then finally, testicular cancer, speaking to young men for a second, it's the second leading cause of cancer in younger men. It's the most common cancer in young men in the sense of it's readily diagnosed from men between the ages of 18 and 35. And one of the challenges we see with that is really around that education. I think to what Sal was talking about is younger men, as you looked at the statistics about when they're accessing care in their younger years, often they don't go, or they're not aware of the challenges that they may be subject to. And if you look at testicular cancer, unlike prostate cancer, one of the opportunities with testicular cancer is that if caught early, it's highly treatable and highly survivable. So if caught in what's called localized disease, so it's in the testicle, as opposed to metastatic disease, which means it's left the testicle and go to other parts of the body. If caught in that localized state and treated, in some cases it can just be monitored, there's a 95% survivability rate for testicular cancer. So there's a little bit of a challenge between those 2 types of cancers as to when you're engaging men. And with testicular cancer, it's really around raising that awareness, educating young men to go access the care that they need if they have a problem with one of their testicles. So when we step back and look at this challenge, and it aligns with what the Men's Health Network does and other allies in this space, is what are our 2030 goals as a foundation? So from our perspective, we look to reduce the deaths in prostate and testicular cancer by 50%. So right now, there's about 27,000 men that pass from prostate cancer in a given year, and about 1,000 men that die from testicular cancer. The challenge with that 1,000, as an example, is that that's that last mile problem. It's how do we drive that number as close to 0 as possible? And in that case, it's really around prevention and early detection. How do we educate men on the challenges they face, raise their awareness, and then when they have a problem, actually access care? With respect to suicide, which is obviously a challenge to what Sal was talking about, we see it a particular challenge, particularly within the current environment around COVID-19 and the pandemic, the loss of jobs, the economy going south, and then also the rise in social justice movements. There's a unique set of challenges that ultimately are going to challenge what we're seeing within the mental health space around poorer mental health as a result of the pandemic and other extenuating circumstances, and the challenges with both the rise in substance use and the rise in suicide. So our hope is, in 10 years, is that we, alongside Men's Health Network, the American Foundation for Suicide Prevention, the Southern Plains Tribal Health Board, and others that are talking about this issue and working on this, that we collectively can reduce that suicide rate by 25%. So if you do the math, that's about 8,000 lives. And then finally, when we look at health outcomes for prostate or testicular cancer, or side effects or complications or comorbidities from cancer treatment, one of the things that we've seen, not only in investing in biomedical research, is also helping men today. So ultimately, we want to drive the number of men experiencing mental or physical side effects from cancer treatment down by 50%. And a lot of that is around the idea of raising awareness for testicular cancer and going to see a doctor earlier if you find a problem, as well as if you are in treatment, making the right decisions around that treatment with your clinical team and your clinical group. So we focus a lot on this idea around how do we intervene early when a man is diagnosed with prostate cancer and help them drive to the right decision treatments for them. So really focusing on, if you were to ask a man in 5 years' time post-treatment, what does your life look like, or what do you want your life to look like, navigating that decision point in treatment, so that is the ultimate outcome. So how are we going to get there? And I think this speaks a lot to what Sal was talking about, of first giving men facts, helping them understand what risks they face, raising the consciousness at an individual, a community, and then a societal level of the challenges that men face around the conversations with respect to suicide, around the conversation with respect to prostate cancer, and then providing them the tools. So similar in kind to what we saw from Sal, and what we do is we focus in suicide on the prevention end of the spectrum. So there's prevention, early intervention, and then treatment and care, or in particular case of suicide, the acute end of the spectrum where someone is in crisis. Our approach is really looking at not only giving men the facts and helping raise their awareness and consciousness about challenges that they may face, but also providing them tools. And to the point that we see a unique challenge right now is within telehealth, and how do we provide tools in an environment where a man not be comfortable going to a place or space, might be more comfortable engaging in health online, or might not be able to get to a physical space for their treatment or care. And then probably the most challenging thing, and this is the, in our world, and what was being talked about earlier, is the changing the behavior for the better. So behavioral change is incredibly important in this, but also difficult to do, particularly as you look at what Sal was sharing through on some of the statistics. This is the, for lack of a better way of saying it, the duct tape and dirt problem. You know, there's no opportunity, particularly in older populations of men, to really talk about, well, there's no vulnerability, or that identifying yourself as having a mental health or physical health challenge is showing that you're not truly a man. And I think the real challenge here is that duct tape and dirt problem really keeps men from changing behavior. So how do we provide them with the facts and the tools to ultimately, over time, change their behavior around their own healthcare and those around them? And then one of the things here is really, and we'll talk a little bit about making connections, is what we're doing in funding breakthrough research. So whether it be in mental health and suicide prevention, or prostate or testicular cancer, as a global foundation, we have an opportunity to innovate in different spaces. So much like we're doing work in the Native American populations here, we're also doing work in Northern Canada with the Nunavut province around young men and suicide rates in smaller communities in Northern Canada. And what that allows us to do is understand how it works culturally and build that cultural competence within those communities, driven by that community leading us to understand what works for them. So that's a really unique position that we have, is that we can focus on those types of efforts and really let the communities lead how they want to engage in that particular issue. And then finally, I think to the point that we've all talked about, is influencing service models so they work for men. So a very simple way to look at this is thinking about language and how men access language. So a lot of times when you go to a health setting, or you're talking to men about health care, the language that's presented back to them is often seeking help, which is somewhat of a language barrier for men. Men like to take action. So when we talk to men about prostate cancer and taking action for their own health, it's really just that subtle change in language engages men more in thinking about what they might be at risk for, understanding their risks, and also engaging in the health system. So there is challenges around advocacy of getting health systems and access to care to be more geared towards men in particular settings. So really influencing service models, not only going to see a clinician, but also how we're talking about in the public health sector, of engaging men in that conversation and influencing the models that are there to serve men. So what's our focus? And I talked about this a little bit before, but obviously evidence-based approaches to all of our work is critically important. But when we step back and look at how do we invest across those three areas, and particularly within mental health and suicide prevention, is the foundational research. So investing in biomedical research for prostate and testicular cancer, but also background research and really understanding what's the evidence for the work that we're doing, and what's the evidence show us about the challenges that men face with respect to mental health. And then in the mental health lens, just to focus on that for the conversation today, is really we spend our time, as I mentioned before, in prevention. Less so in early intervention and treatment and care. So when we think about what we're doing in ANADARKO and other sites within the Making Connections, it's really around the preventative lens and using a community-based approach to that work. And then ideally intervening early, allowing that community to upskill themselves and then having them intervene early when a boy or a man is challenged with a mental health issue. And then finally, treatment and care. That's really towards our cancer work and what we're doing there. We don't spend a lot of time. We're not competent, quite frankly, enough to be in the acute end of the mental health crisis around someone who might be ideating or in an acute crisis situation around their mental health. So talk a little bit deeper about the mental health challenge here. So what is the problem? And I think this points to what Sal was talking about as well, is the statistics are daunting. So 3 out of 4 suicides in the US are men. If you actually look at that globally, that statistics in most of the markets that we work in, of the 21 that we operate in, that is largely the same. So to the point earlier, it's not just in America that we're having this challenge. There certainly are some very unique systemic historical issues that we face in this country that are different in kind, but in general, men are not doing well in the markets that we work in. It's the second leading cause of death amongst men between the ages of 10 and 34, and as you look into disadvantaged or marginalized populations, that's even more dire. It's becoming a unique challenge, and we found that issue as we started working with Susan and others in ANADARKO around what some of the young boys were facing in that community. And if you look at the numbers, about 48,000 Americans die by suicide. So very simple math there as to how many of those are men. It's a unique challenge, and I think in the current environment with COVID and all of the antecedent issues that were there, as well as the issues that are coming with result of job loss, loss of economic security, housing, etc. Unfortunately, we see that those numbers will probably increase, at least for the short term, so we have more work to do. And then it's the 10th leading cause of death in the US, according to the CDC. So one of the challenges you see there is you look at the top 10 reasons, most of those are physically based challenges, and men fare less well than women against those top 10 diseases. But suicide, which is tied to mental health, is really the one behavioral health back issue on that list. So it's becoming more and more of a problem in this country as well as globally. Just to lead out with this, if you look at this globally, there's about, according to WHO, there's about 800,000 individuals each year known that decide to take their own lives. About 500,000 of those are men. So that's 60 men an hour, if you do the math, which is a daunting statistic. So I won't spend a lot of time here, but what have we been doing in this space? So we've been working in mental health and suicide prevention for 14 years, since 2006. We started our work in the US in 2014, so we've been in the space in the US and had done a lot of learning in Australia, Canada, and a few other markets prior to that, but landed in our thinking around mental health and suicide prevention in the US in 2014. So we've invested in about 140 projects globally, and you can see the populations we focus on. So young men, how can we service young men as they're growing up? So I think to the point earlier, looking at that behavioral change and getting to men earlier in their lives to really better engage them in understanding the risks they face, raising their consciousness, and actually changing their behavior about how they access healthcare. Fathers, clearly is a very transitional period in a man's life. So father for the first time, father for the third time, those that are father figures who are raising children. The real challenge with that is how do we engage men more in raising their children, because we know that has a positive effect on the mental health of not only the father, but the family and the children as well. So better modeling of behaviors amongst fatherhood and fathers. How do we engage in that conversation? Indigenous communities, as I mentioned, we do work in making connections here in the US, as well in other markets with Aboriginal communities in Australasia, whether it be Maori or Aboriginals in Australia, as well as in Northern Canada. So focusing on that community, because we obviously realize the challenges when you look at the statistics and some of the historical challenges with respect to how those communities have been treated. And then workplace and online. So we know men are having conversations in workplace. It's a way to engage them through their employers. And then online, as we all know, there's a bit of toxicity that sits in online communities of men these days. So how do we engage and change that conversation? And how do we engage men when they're talking online, whether it be in a gaming community, whether it be in a Facebook community, to really start influencing healthy masculinity and healthy conversation amongst those populations of men? So when we look at suicide, just to talk about it for a second, so it's complex. and it's really caused by any single factor. It's multivariate. Many people who die by suicide are not known to have a diagnosed mental health condition at the time of their death. So when you think about the issue, it's not as if it's always been there or they have to have an underlying diagnosis of depression or anxiety. Problems often contribute to suicide, as I've talked about, which is around relationships, so a loss of a relationship or breakup of a marriage, substance use, physical health, so poor physical health, being injured on the job, loss of a job, money, legal, or housing stress. So it's a multifactorial, multivariate challenge that we see. And what we've done is take a step back and look at who is working in certain spaces, and then where does Movember fit within the work and the challenges that we see for men in particular. So when we step back and look at here's the problem, what's the solution? Solution should involve obviously a range of organizations and stakeholders. To my point earlier, those 2030 goals that we've set out for ourselves is not just Movember alone. It takes this conversation, it takes the Men's Health Network, it takes ourselves, it takes the community and society to really lean into this challenge and understand how do we move it in the positive direction. So it's not just individuals, but it's governments, it's public health, it's employers, it's education, media, etc. So if you look at the CDC's recommendations and the ways to approach this issue, how do you implement suicide strategies that require participation across a unique set of stakeholders from various settings and sectors? So first thing is to reduce factors that increase risk of suicide. So how do we look at trauma that may exist in a community or for an individual boy or man and reduce the factors that create that trauma? That's a unique challenge, and it's a very difficult one. But first things first is to stem the issue where you can to decrease men being exposed or boys being exposed to trauma. And then second to that is increase factors that promote resilience and coping. So our work in Making Connections is focused on how do we build resilience and coping skills for young men and boys, as well as veterans. So looking at all levels of society from individual, family to community to drive that broader social environment around promoting resilience, pushing back on the less healthy aspects of how boys and men are raised and masculinity, to find those and build those coping and resilience skills for men and boys. And then prevention strategies really need to promote awareness of suicide. So that's the conversation today and the conversation that both ourselves and the Men's Health Network have every single day, promoting prevention, resilience, and then a commitment to the social change. So thinking about the current environment, how do we lean into the challenges that we know have been there for generations, if not hundreds of years for certain communities in the US? How do we really start engaging in that social change, that social justice conversation around what challenges we see? So I won't go through this all in general. It's pretty lengthy, but again, as we look at our work in prevention and early intervention, what is it and how does it evolve? So really it drives from this idea of building protective factors, those coping and resilience skills, ideally driving more access to care for men. So there are diagnoses or engaging men when they might be ideating or attempting suicide. And then early intervention is really getting them into a space or place where we intervene earlier. So where it's relatively low intensity. So it's not a boiling challenge. It's something that is there, but something that can be stemmed earlier and engaged earlier. And then supporting the well-being of men in major life domains. So those points in time that we talked about are around job or relationship loss, around housing or economic security. How do we engage them earlier as those things are happening so we can put them on a more positive path? So this is, if you step back and look at the CDC, here's what they say about how do you prevent suicide. So the real challenge here is, of all the strategies, where does Movember best fit? So we don't do, even though we have small pieces of work in some of the things that aren't highlighted in terms of where we spend our time, but most of our work and where we feel we have a strength in supporting this alongside others that are in this space looking at this and working on this issue is around connectedness, coping skills, and identifying and supporting people at risk. So a lot of our work is around that social connection, that glue that happens in places and spaces for men, that language that they they use, getting them to have a deeper conversation about challenges they may face, and providing an open ear on the other side of that conversation that is willing to engage in that conversation and let those men talk and listen to them. So where do we focus in terms of priority groups? Just quickly here, young men obviously is an area of focus for us. We're doing work within the Making Connections initiative and other projects around the globe around younger men. Fathers, as I mentioned, is a key component, particularly as a man is first becoming a father, as well as how he's projecting positive role modeling for those children so they have a different engagement with men in their lives as they grow up. Indigenous communities, as I mentioned, and some of the work that we do across multiple markets, veterans, first responders, so looking at the intersection between veterans and first responders and the trauma that they experience, and then how do we engage them early on. So particularly looking at firefighters and paramedics, often first on the scene of very challenging spaces. How do we engage them when they experience that trauma early in that experience, so we can actually help them navigate through it and develop positive coping and resilience skills. And then men going through tough times in their lives, so that middle-aged male problem. Men are often, when they should be most productive, in some cases losing their job and not productive, and then ultimately end up in a more difficult place with both their physical and mental health. So our areas of focus around strengthening social connections, increasing mental health education, and then raising awareness. And we do that through a multifactorial ways, and I'll talk about that in a bit here. And then organizational strategies, digital tools and resources to the point around telehealth. How do we engage men outside the four walls of a health system? How do we engage them from the comfort of their home, where they're much more open to having a more detailed conversation with a clinician, whether it be a therapist or an oncologist, and how do we engage them online where they're having these conversations with other men. Fund and implement face-to-face programming, so a lot of this community-based work that we do, and then deliver health awareness and health action campaigns, and I'll talk a little bit about one of the ones that we do with respect to COVID-19. And then just globally, how do we bring this to life? So some of the programs there at the bottom are some of the work that we're doing. I'll speak to Movember conversations in a bit, but Young Men in Sport, Making Connections, Social Innovators Challenge, Well-Beings, which is a initiative we're doing in the US here alongside PBS and WIDA and Ken Burns around a large-scale documentary and education on youth mental health and the youth mental health crisis in America, which is due out in 2022, but really leaning into that and raising the consciousness around the challenges that young people face with respect to their mental health. And so what are the outcomes we seek? So clearly we would think about providing tools, facts, and then changing behavior, really focusing in on increasing the understanding of what works to improve men's health. So even to that point around taking action language as opposed to seeking help. Health services tailored to men's needs. Those around men have an increased understanding how to support men, how to have a conversation with a man in their life that might be struggling. Men are more socially connected to friends, family, and the community. So if you look at the data and some of our work, as men age, they often lose their social connections. How do we strengthen and keep those throughout those lives? Because we know that's a very important preventative factor for poor mental health. That men are equipped to increase understanding of mental health and well-being, and that they take action early to improve their own mental health. And this is pretty much encapsulating everything on a page. So if you look at that 2030 goal, where does Movember fit in what the CDC says are the preventative measures for suicide, and where can we best contribute to reaching that goal alongside others? And then finally, just to speak to what's happening today, obviously with respect to the ongoing public health crisis in mental health, particularly for men, amid the pandemic and some of the challenges that Sal mentioned earlier around what's happening to men and the challenges that men face with respect to COVID-19, and the drive for social justice, which really is underpinned by inequity and lack of access in the healthcare landscape as well. So we conducted a survey of 1,400 Americans, we had about 8,000 participants globally. So we looked at this in all of our major markets to really understand what was happening in men in the moment that the pandemic was starting to really set in each of the different countries that we operate in. And so some of the things we found from that was 88% of men surveyed found it helpful when people ask them if they're having a difficult time. So really just engaging in that conversation is critically important for men. Just asking them how they're doing and not letting them get away with that monosyllabic word of I'm fine. Really digging in and providing tools to help have that conversation. I won't read through all these statistics, but nearly a third of men admitted they felt lonelier more often than before during the outbreak. So that loss of connection in your employer space, as well as the loss of the ability to go to where men typically like to spend their time, sporting places, you know, let's call it for what it is, going to bars and hanging out, watching a game, places where men typically congregate, barbershops, because they've lost that place and space to go to connect with other men. They often have felt more lonely since the onset of physical distancing and closing down of infrastructure. And said more than half of men said they felt the same as they did before the pandemic began. That's a positive indicator, but ultimately the underlying challenge is how engaged are men in their own health, and do they feel the same, as in, are they positive prior to, or are they just the same in terms of they're stuck in neutral? So some real challenges there. So some of the stuff we brought forward as we look at this is really around a piece of awareness campaign around spotting a bro who's feeling low. So bro is how we talk about our Mobros in the Movember community. So engaging in a piece of awareness raising around that guy that might not be engaging you as much, you know, in your fantasy football league or in your local community setting at the local church because they can't get there. How do we find those men? How do we help individuals identify those men in their own lives and then reach out either through the 5-a-day challenge, so take those 5 minutes each day that we've been promoting out, and then leveraging the model we developed with a group out of Australia called Are You Okay?, which focuses on suicide prevention, which is really around ask, listen, encourage action, and then check back in. So it's a very simple model to go through. How do you ask a man how he's doing, and then listen without judgment, encourage action. So don't try to solve the problem for that man, but encourage them to take action for their own health, and then check back in, making sure you follow up with them to see how things are going. And then Movember conversations, I'll go to that in a second, but leveraging the ALEC framework, thinking about reaching out to a man on a given day for 5 minutes just to check in, and how do you have that conversation? So it is difficult to get men to open up in some cases. So we built an online platform called Movember Conversations, which really helps individuals understand how do you engage a man in that conversation. And then I won't go through all this, but just to highlight the program spotlight here around men and boys of color and veterans. So our Making Connections initiative, which has been in the US since 2014. It's one of our flagship pieces of work at the community level around community-based intervention. So the challenge here obviously is mental health issues are often aggravated in communities that are already at risk. So those that are disadvantaged or marginalized. And then what are the opportunities when we look at how do we undertake this effort? So really reframing the concept around mental health to include well-being and resilience. That is not just poor mental health, but how do we look at well-being and how do we build coping and resilience in these communities? And as you can see here, we work across a number of different communities across a number of different states on this particular issue, really trying to drive, does what we're doing at a community-based intervention or prevention level work? And is it culturally competent for the communities that we're in, and does it work for them? So the program spotlight here to talk about obviously is to highlight the work that is being done by Susan and the team and ANADARKO with the Hope Squad. One of the challenges for folks that know is that in 2016 there was a suicide cluster amongst the population, and how do we engage in that piece of work and really look to Susan and the team and the community to inform what works best for that community. So there's a competency, there's an awareness around what works to engage in the challenge of what was happening with younger men and girls in that community around suicide and poor mental health. So it's been really exciting to watch that experience over the last several years as to how Hope Squad and what's happening in the schools in ANADARKO, the positive outcomes of some of that work, that we're slowly moving that dial and building that coping and resilience in that community. And then lastly, on Movember Conversations, just to point this out. So if you go to conversations.movember.com, it's in beta. We have a lot of work to do, but the intent here with this is to start building competency. So just to call it out, today it does not have a Spanish version. It doesn't, it's not in other languages that we know are incredibly important. It is really looking at how do we start engaging men in conversation? How do we provide tools to carers or caregivers or of men to help with that conversation and leveraging ALEC. So as we continue to build this out, we're looking at how do we take this to certain communities? How do we work with those communities to talk in a culturally competent way so that when people are using this tool, it speaks to them in a language that they understand. So that's the piece of work that we invested in over the last several years and have brought forward as a result of what's happening with the pandemic and the social justice movement here in the US. And with that, I will stop and like Sal, I'm happy to share these slides with the community as we move forward, and happy to take questions. Here's my email. Anyone that has any questions, and I'll turn it back over to Susan.
Thank you both so much for your excellent presentations. Really was a wealth of information, and thank you for consenting to share your slides, because that was one of the questions that was asked. I will try to, there are some questions in the chat, so let me see if I can, Idalmi, can you check the ones in the chat, and I'll check the ones here. Okay. So one of the questions was, in what ways do the suicide prevention programs in Indigenous communities address the detrimental impacts of cultural hegemony and hegemonic masculinity, which means, like, you know, supremacy of the dominant culture or whatever. So if any of you want to speak to that, and I can also add a little bit as far as our own program goes, but I'll let you speak to that, both Dr. Sal.
Sure. Yeah, and I'll start, and I think, Susan, it'd be really good to get your perspective on how this works in your community. So just to recognize up front, we have a lot more work to do from the Foundation's perspective in this space. We have been committed to this work in Indigenous communities for quite some time, but our approach really is letting the community own the process and what they want to ultimately do within their own community. So when you think about white supremacy or hegemony and the challenges that present, as we looked at in ANADARKO, we know there's a historical systemic challenges in that community and in Indigenous communities across the globe. Our role in that is really to provide the funding and resource to help that community engage in the right way. You know, very clearly, we're not culturally competent in some of these communities ourselves as a foundation. We want to be led by that community and those who are experts in that community to help them. And I think that's probably the most important point, is when it comes to some of these long-term historical issues around white supremacy and hegemony and a very monolithic view of health for centuries, our approach is really to step back and say, how do we help men in these disadvantaged or marginalized populations and let them lead us as to what works for them? Because I think if you were to look at suicide, and to what Sal was talking about and what I was talking about within marginalized communities, it's a incredibly difficult and multivariate piece of work. And we want to be led by that community in helping solve for that problem. So it's really for us to listen in that and just provide the resource to help that community address that issue for themselves.
Thank you. Dr. Sal, would you like to?
There we go. I totally agree. It's a very understudied, underappreciated area. One of the things that's amazing to me when I speak about mental health in boys and men, or even really any health-related issue in boys and men, is people tend to think of men as one large homogenous group. And I constantly feel I should mention that there are various demographic groups in men, and while there's precious little information designed or studied men in general, there's even less when you look at sociocultural overlays to different communities, regions, organizational structures, gender identity, very little work. Men's Health Network is trying to approach that. We partner with the National Black Men's Health Association in a lot of our projects. We are engaged in a very large project that's being funded graciously by PCORI, a large funding entity, to help understand not just some of the fundamentals about mental health challenges, but how do you drill down to these, as Mark said, at the sociocultural level. There's a long way to go and not a lot of work done before now. So hopefully that's changing.
Okay, thank you. Also, to speak to the question, I think a key aspect is allowing, as you both said, allowing the community to be involved in they think is best for them. And in Native American communities, culture is a big part. Actually, there's a whole campaign around culture as prevention. So prevention issues, whether it's substance abuse issues or mental health issues, culture is a big part. So one of the things that, that we focus on, actually during this Men's Health Month, we're going to be having a hand drum and drumstick making class on Friday for young men in ANADARKO, right? Connecting them to their cultural traditions and practices and, engaging them in dialogue and in things that help build their resiliency are so important. So that is a way that, that throughout this program that we have looked to the community. We have got American Indians involved, even in partnering with the Hope Squad program. We've invited the community to come in, and that means there are several tribes in Caddo County where ANADARKO is located. So we have, whenever we do the Hope Squad modules, we've invited tribal organizations and other community organizations to come in and be a practical part of helping the young people. So like Kiowa Teen Suicide Program and RISE program and some of those Native Americans. So they're able to bring in that cultural aspect and to help the young people. So again, culture as prevention is a big part of what we have been focusing on through this program.
Yeah, I think that's really important, Susan. And the work we're doing in making connections in ANADARKO, we're doing work in Hawaii in a disadvantaged lower income community that is largely comprised of Pacific Islanders or descendants of Pacific Islanders, and that community, that sense of space, that connection point there is a bike shop. And it's bringing young boys and men from that community together in a space and place where they can start having that conversation, where it feels to that community that's where it's a center for them to get together. And really, I think the opportunity there is looking at the cultural competence of the community and understanding some of the preventative factors that sit within what are historically strength points for those communities to really engage in that conversation. And I'm happy to share after as well, Susan, we, much like I had the link in the piece about ANADARKO, as you know, we did a short piece about 8 minutes on what is happening in that community in Oklahoma. We have another one around the Hawaii site, and then there's one out of Northern Canada, as I mentioned, in Nunavut, which is really around land-based activities. So they too were suffering from the challenges of being marginalized for an extended period of time. They had lost connection to the land. They had to fight incredibly hard to get autonomy within Canada for a long period of time, but then they were experiencing high rates of suicide amongst their young population. So that program is really looking at how do they get the older men in that community and the younger men in that community going out and doing land-based activities around providing sustenance and food and re-engaging in the environment and culture around them. So we see that as a really good preventative measure that organically is happening in that community and in ANADARKO and Hawaii that is really important for us to lean into and say what works for that community. So I think it's incredibly important to continue to honor and focus on that.
I'd also add there is again here a stunning lack of research to help guide what we do and understand what we do. Men's Health Network is being funded to develop in part, part of our strategy is to develop important research questions. So we're actually holding some conferences about that later this year to help define important research questions, to look very much at the whole issue of community involvement, what works, what has a good outcome, what doesn't work, how to implement these things, how to get support for them. Because right now there's just not a lot of information, scientific information, being the geek that I tend to be, that helps guide what people need to do.
Thank you for that. To go to another question, I think this question came in during Mark's presentation. It says, what were the demographics for the men being studied?
So I think we look at different, from our perspective, and I know Sal does a lot of work in this space as well. From our perspective, we look at men in general. So what does the data tell us from the CDC, WHO, and complementary organizations in other markets? But then as we look at, as I mentioned, fathers, men between a certain age or population, middle lifers in certain markets of lower socioeconomic status, trying to understand demographically what's happening in certain communities when you tease apart the challenges of substance use or suicide attempts and/or successful suicides. So pulling those apart and really understanding demographically what's happening. And as I mentioned, if you look at where Movember best fits amongst the ways to prevent suicide, according to the CDC, is in a couple key areas. We don't, even though we're coming alongside folks that are working on housing issues or job issues, that's not the focus of our work. It's really around that social connection and building resilience. But the data, when we looked at making connections, which is a big piece of work in the US, we did step back and look at where we knew there were going to be challenges already that we're presenting in, to Sal's point, a relatively small data set around challenges within marginalized community or communities of color. The issue there was what's happening there. What are the rates of suicide? What are the rates of substance use and mental health and depression, anxiety, to really drive at how did we want to design that program to best meet those cultural competencies and needs within those communities. So it's a hard thing to tease, but if you look at the CDC data and WHO, I mean, as you start to pull it apart, you can see where the challenges sit in the data set in the communities that are particularly impacted by things like mental health or poor mental health.
We're trying very hard to understand this by various demographics, including racial demographics. One of the interesting facts is I'm trying real hard to understand what talking about COVID, which I think is one of the main focuses of this review, is how we know that men are disproportionately affected in terms of mortality and morbidity, getting it and dying from it, but how also does that stratify across racial lines? We can't get the data. I've called CDC, I've texted CDC, we can't get the data. So one of our general beefs, if you will, is that top line data really, if it doesn't really always address the gender issues, let alone the socioeconomic, ethnic, or racial issues. It is one glob if you can stratify out the men's health data at all. So we're constantly asking organizations who are data drivers to put that data up front and not make us search hours and hours and hours for all that information. Pardon me. That's a big problem.
Okay, thank you. Mark, during your presentation, you alluded to a survey that was done around COVID-19. How did you collect that data, and who were the participants or who were the respondents to the survey?
So we worked with a social research center out of the UK to do that piece of work in 6 markets. So the UK, Canada, the US, Australia, New Zealand, and Ireland. So that was done through a survey research organization. It was really early on in the pandemic as we saw it unfolding and understanding that we knew there were going to be challenges for men, particularly as you started thinking about job loss and economic insecurity alone. working from home for fathers has presented a unique challenge in my own life around, how do we manage all of a sudden your whole family is within your workspace at the same time that you're trying to do homeschooling. So we did that piece of work early on in March as we saw the pandemic unfolding. And as I said, there was about 1,800 respondents in the U.S. In terms of the demographic breakdown, I can take a look at that. I don't know how that looks from the demographics as to what that population of men looked like, but it was fairly evenly split between men and women, because we did want to understand what women were experiencing, because I think something that Sal brought up earlier, the real challenge in men's health right now is that men aren't engaging. They don't know how to talk. They don't know how to access healthcare, and that women play an important part and preventative factor in a man's health, whether it be mental or physical, of engaging them. So leveraging ALEC model, et cetera, is incredibly important for us getting that out to women. So we did want to listen to women as well as understanding, what's happening to the men in their lives as a result of this. So, but yeah, I'm happy to provide a little bit more background on the demographics for that piece of work.
Okay, thank you. Do you have a question?
I kind of wanted to know about.
Oh, you can go ahead and.
I don't think I can do an echo.
Oh, I can turn off mine. My coworker has a question, so I'll let her go ahead and ask.
Can you guys hear me?
Now we can.
Is it better now? Can you both hear me well? No echo?
Yes.
Sorry about that. I just wanted to know if you guys had seen any data or research in the area of health literacy and COVID-19, especially when it comes to people who speak other languages. I know that I'm glad that Mark brought up the point that they're working on the Conversations program, and the thought of other languages coming into play is important, because I feel like sometimes the focus is on English, and also I know that people have had difficulty understanding basic terms such as pandemic. Not everyone had heard of that word before COVID-19, so I was wondering if you guys could have some input on that aspect of the lack sometimes of understanding basic terms, especially in other languages.
I am not aware of any real systemic data specific to COVID-19 now, and that's one of the deficiencies. I think when you look across health literacy in general, there are tremendous challenges, and a lot of that has been homogenized. That is to say, it's general health literacy. There's a little bit of information I'm aware of. I know Pfizer had done a lot of work on this in past years in the area of health literacy. There's a little bit of information that's stratified by gender, but certainly not enough. And then when you look at it stratified by ethnicity, sociocultural norms, there is some, but not a tremendous amount. With respect to COVID-19, I'm sure that data will come. I think the best we can do now is apply what we have learned, which is a tenet of public health communication, which is you have to learn how to communicate to the target audience in a way that they do it. Men's Health Network has had a lot of success in doing that in the men's health space. There's just not a lot now in COVID. The priorities, I think, are just understanding the virus as well as understanding how to get information out in a proper way. That hopefully will come soon.
Yeah, I think it's an incredibly, it goes to that vocabulary conversation we've been having, which is seek help versus take action. If you extend that back into acknowledgement with Movember Conversations that it is English only right now, our hope is that it moves into other languages rather quickly here. But what we have learned in the prostate cancer space, we have a product called True North, which is really around that point of early intervention at the moment of diagnosis through treatment and care. That actually exists in 20 languages. So we've been doing a lot of work in that space around elevating and using language that works for men and is culturally competent for different populations of men. So how you talk about prostate cancer in different communities is going to be very different, and it has to have a cultural lens. You think about African-American men and the cultural components of talking about disease, or let's be honest, things like erectile dysfunction. In certain populations, it's hard to explain, and or you have to come at it from a certain perspective. So we have been doing a lot of work in that space. And I think even in terms of content, to Sal's point around how do you show up in that conversation, our work on content within True North, which we look to bring to things like Movember conversations, not only language and expansive language, but competency. And when you access that product, when you're an African-American male, for instance, and you sit in a certain group of clinical outcomes, having a man that looks and speaks to you is really important. It's not, the guy in the lab coat talking about the very clinical thing and using, 20th grade reading level language. It's really a guy that's looks like you and talks like you, talking in a conversation that makes it more relevant for you. So there's a lot of work being done in a number of different spaces. We focus on it within cancer right now around really having that content, that language, who shows up on the other side of that screen in a telehealth conversation to look like and feel more competent and comfortable in that conversation.
That's very important. Men's Health Network makes a conscious effort to translate things into Spanish, and we have several brochures in Spanish, but we just can't translate into all the different languages. But to your point, Mark, very important, you relate well to the individuals who look like you or in your social circumstances. I've just finished a project, I think it's almost completed, with CDC on prostate cancer decision-making for men. And that's one of the areas that I stress, that you just can't homogenize the male population. Again, going back to the basics of public health communications. So hopefully we'll see how that turns out, but we're well aware. We're over the need for that.
To speak to that issue too, I have done a lot of training around health literacy and have done trainings on health literacy. That's something that I'm pretty passionate about. So when this pandemic hit, as one trained in health literacy, I created a brochure, a pamphlet really, with common terms that were being used. And that is on our website, SPTHB website. I'll be happy to share it with anyone, with you guys, with your organizations. And also, I think I shared it with Prevention Institute and Susan from Movember. But also, I also wrote an article which was published in a magazine this month called Health Literacy, the Importance of Health Literacy During the COVID-19 Pandemic. So yeah, just keeping that on our radar and knowing that, it entails a lot of stuff, not just, the whole language thing, but how people respond when there's a crisis, a health crisis, whether it's a personal crisis or a public health crisis, So all of these things are important aspects, but I will share that with you two presenters, and anyone else who would like to can also.
Thank you.
No, that'd be great.
Yeah. Are there any other questions from our attendees? If anyone would like to ask a question, you can raise your hand and I will unmute you. We have 5 minutes left. Any other questions or comments?
May I ask a question of Mark?
Sure.
Yeah, when you do your work globally, are you finding significant global differences in the overall health status of men? Do you find that the problems and the vexations and the approaches are same, that there's a lack of data, that there's a lack of political focus on guys to drive things? We don't have an NIH budget specifically for guys in the US. Are you finding that this is a US-centric problem, or do these things systemically affect guys throughout the globe?
Yeah, I think it's a systemic issue at the top line. So of the countries in the world, of the 180 plus, there is only one that has a federal level government agency for men's health, and that's Australia. There isn't one in any other market in the world. I think there might be one in Libya, of all places, but that's really it. So that consciousness, that the conversation, I think, Sally, you were talking about around men's health and some of the challenges that are unique to men, and you see it in the numbers with suicide and life expectancy, that's not really the consciousness. I know WHO has started to lean into this conversation a lot more because they recognize some of the challenges with suicidality and substance use amongst men. But in general, when you look at the markets, no, there really isn't a consciousness anywhere in the world around this issue collectively. It is still very much cottage and small in terms of how we're approaching the issue.
Yeah, one of the first things we did when we were able to recognize men as a demographic within the American Public Health Association was we issued the first, and to my knowledge, the only major health association's statement on men's health, and with a format for changing the future, where we described we wanted to reduce the mortality difference between men and women by 50% in 5 years. We're not quite at that goal. In fact, we've shrunk it a little bit. But when you talk about things such as guidelines, we talked about testicular cancer screening and the importance of self-exam. We understand how effective that's been in women for breast cancer. The U.S. Preventive Services Task Force discourages testicular self-exam in men. When you look at guidelines for screening about mental health, they are homogenized. There is nothing there specifically for the guys. There's a very important statement about screening for postpartum depression in women, but when you look at guidelines as to when to screen men and women for mental health issues, there's precious little that speaks to the issue for guys. I was just reading U.S. Preventive Services Task Force screening guidelines on hypertension. They're recommending men get screened every 3 to 5 years. Really? Every 3 to 5 years? And they're recommending guys over 40 or with pre-existing conditions or dispositions to be screened every year. Really? 1 year? So I think part of what we face is, particularly as health insurance reimbursement is guided by these national guidelines, if you will, is to make sure that the guidelines also approach the issues of men by ethnicity, sociocultural need, and not just homogenize them. So that's a big issue we're bird dogging at Men's Health Network these days.
Susan, I think there was a question that came in from.
I'm about to ask. Sal, can you tell us a little about the American Public Health Association's Men's Health Caucus and the Congressional Men's Health Caucus / Prostate Cancer Task Force?
Yeah, these are things that Men's Health Network has been intimately involved with for a long time. In 1994, the caucus, Men's Health Caucus in Congress was established. It does look at legislation and it does advocate within federal legislatures for issues, funding, very specific to boys and men, and we're very grateful for that. The American Public Health Association, and for those who might not know, is the largest organized public health association in the world. Men's Health Network's caucus was established with the help of Men's Health Network and other individuals in academia and the public health community who felt that men really did need to have some area of focus, and they are always looking for members we have poster presentations at the annual meetings, we have platform presentations, we're constantly talking about focusing research on just some of the things that Mark and I identified here that look at the various demographics of men. So it's a very important strategic platform to advance the health of men's health, to advance men's health. NIH, we're also advocating through APHA and Men's Health Network and National Black Men's Health Association for research dollars and an Office of Men's Health. There is one for women in HHS, but there isn't yet one for men. There was an Office of Native American Indian Health that was established some years ago, but wasn't funded very well. So, there are a lot of fundamental things that need to be done at the public policy, legislative advocacy areas that Men's Health Network and aligned organizations work very hard at. But it's a tough slog. It's a tough slog. Thank you for the question.
Thank you. Thank you. Thank you both. And thank you to our attendees. We have really learned a lot about men's health, and because of these issues that men face generally, then we can see how and why COVID-19 has been impacting men's health more so than other demographics. So thank you both, Dr. Sal, and thank you, Mark, so much.
My pleasure.
If you would like to get a copy of the slides, feel free to contact me. My email address is S for Susan, and then gay at spthb.org. And that is for Southern Plains Tribal Health Board. And again, this presentation is being recorded, so it will be uploaded to our website eventually. So thank you again, and this concludes our fourth and final webinar for our Let's Hear It for the Warriors campaign for our Men's Health Month. So thank you so much to everyone who has attended all 4 webinars, and for those who have attended this one as well. Thank you.
Thank you for having us.
Thank you, everyone.
Okay.
Take care.